This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
And welcome to the human side of healthcare. We're delighted that you've joined us this Sunday, and we've got a special treat for you today. We've got Mr. John M. Barry as our guest. He is a professor at the Tulane University School of Public Health and Tropical Medicine and a distinguished scholar at Tulane's Bywater Institute. Many of you know that he wrote the book, The Rising Tide, about the Mississippi flood in 1927. But we're going to talk to him today about, obviously, COVID-19 and a book he wrote, The Great Influenza, about the flu epidemic and pandemic in 1918. Thank you for being on our show.
You're very welcome. It's a pleasure. And since I'm talking to folks in Texas, let's not leave out the fact that I was a football coach for a while.
Did you coach here in Texas?
Actually, I was a coach on a Tulane team that was 45 years ago. Had the best record in 25 years, beat an Orange Bowl LSU team. They were number 5, we were number 11. But then we went to the old Astro Bluebonnet Bowl when University of Houston was just beginning to emerge, and they killed us.
Well, that's the way it is in football. But that's right. You were a football coach. Well, thank you for being with us. You know, I've read your book, The Great Influenza, and I was going to ask you a couple of questions about it and then kind of pick your brain related to COVID-19. For many of our listeners, they may not know the Great Influenza that started in 1918. In your book, you describe how 613 American troops were admitted to a hospital initially, and only one died. And in a British fleet, there were 10,313 sailors that got infected, and only 4 died. Can you explain kind of the 3-day fever and then how it turned into a real lethal infection?
Right. The key is that influenza, unlike COVID-19, influenza is one of the fastest mutating viruses in existence. And there was a first wave in the spring of 1918 that was not widespread. A lot of places didn't see any evidence of influenza whatsoever. And those that did, it was generally pretty mild, in fact, very mild, as you just recounted. There were even medical journal articles saying this looks and smells like influenza, but it can't really be influenza because it's not killing enough people. But apparently the virus mutated and came back with a real, truly killing force in the fall. In total, the 1918 pandemic killed between 50 and 100 million people. If you adjust for population, that would be equivalent to like 220 to 440 million people today. Now, fortunately, there are 2 things. Number one, there isn't the slightest sign anywhere in the world, and there is a tremendous amount of surveillance and analysis of the genome and so forth and so on. There's no sign that this virus is mutating in any direction toward virulence. It's a much more stable virus than influenza. And secondly, it's plenty dangerous as it is. But fortunately, it is not as virulent as the 1918 virus.
You know, in reading your book, and I know you said this was speculation and it had not been proven, but there was a theory that in February of 1918, that potentially this pandemic, or at least the spread of the virus, may have come out of Haskell County, Kansas, and it potentially went from a pig to a human being. That's just one theory, I assume. Do you have any thoughts on that?
I do. There's been the book originally came out in 2004. There's been a lot of work since then. And I believe that I had located, in fact, I still believe that I had located the first outbreak reported anywhere in the world of a violent form of influenza. That was in Haskell, Kansas, which is actually not that far from the Texas border on the southwest corner of Kansas, near that narrow strip of Oklahoma above Texas. That was actually in late January 1918, and you could trace people going from this rural area in Kansas to previously the first known outbreak, which was at an Army base for what is now Fort Riley. But work since the book came out, has convinced me that my favorite site of origin now is probably China, although Kansas is still a possibility. Other hypotheses out there are France in 1915, and Vietnam, and New York City is actually a possibility. We now know that there was an outbreak in New York City in February, probably a little bit later than Haskell, but we don't know. Maybe it was a little bit before. Possibly there was some movement of people from Haskell to New York, or the other way around. It's not in China, but the evidence for China is chiefly that China was not particularly hard hit in the fall wave when everybody else was very hard hit, which pretty strongly suggests they had some immune protection because they had been exposed to the virus before. But we don't know, and we'll probably never know.
In reading your book, this particular 1918 influenza really had waves. It came in like 3 waves, and it was amazing. Some areas like California, Iowa, Kentucky, New Orleans that you cited. Also in Savannah, Georgia, I think on January the 15th of 2019, actually had to, for the 3rd time, close public places and theaters. Do you see any similarities from the waves you described in your book and what we're seeing with COVID-19?
The waves are, fairly standard for an influenza pandemic. There are at least 2009, 1968, 1957, 1918, 1889. Those are ones that we've got some fairly good data on. And of course, the more modern ones, we've got a lot of good data. And they did all come in waves. But one thing that's a little bit different about COVID-19 is we intervened to stop the first wave. The lockdowns, which were absolutely necessary to save lives. I mean, had we not done that right now, I'm certain we would have somewhere between 500,000 and 750,000 deaths right now if we hadn't done that. We're at 141,000, even with all the lockdowns. So by stopping that first wave, intervening in it, the exposure of people, which would have happened naturally, ceased. So the whole issue of waves are a little bit different in this outbreak. The other thing is how much summer is going to interfere with transmission. It is true that whether it's influenza or common cold, there is much less of that, much fewer respiratory infections during the summer than there is in the fall or winter for 2 reasons. Number one, the virus does not survive outside in high temperatures as well as it does in colder temperatures. Number 2, people tend to be inside more with poorer ventilation in colder temperatures than they do with warmer temperatures.
This is author John Barry. He wrote The Great Influenza about the 1918 pandemic, and we're comparing it to today. Back with more right after this.
This is the human side of healthcare on 1080 KRLD and the radio.com app, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
And welcome back to the human side of healthcare. We're going to continue our discussion with John Barry. But Thomas, I have a question for you.
Yes.
Do you know why in 1918 it was called the Spanish flu?
I do not know how it got that name.
Well, let me tell you why. And I found it out in his book. We were in World War I. There were many countries that were in the war, as you know, and they did not want to hurt the morale of the people or the troops. So they really kept the epidemic and pandemic out of the news. Spain was neutral. Spain was very transparent. So people read about the flu, the people contracting it, and the deaths in Spain. So it became known as the Spanish flu, even though it didn't originate in Spain at all.
Wow. Boy, that is interesting. So there was a little bit of a news blackout back then. Interesting that correlation might be coming up, and you're going to hear about this in this segment. We're talking to author John Barry. He wrote The Great Influenza, the story of the deadliest pandemic in history. He's a distinguished scholar at Tulane's Bywater Institute and professor at Tulane's School of Public Health and Tropical Medicine. And, of course, he lives in New Orleans.
And you forgot, he's also a former football coach.
Absolutely. Now, let's continue our conversation with John Barry, asking the question, would the summer tap this out?
In April, I actually wrote an op-ed in the Times, the New York Times, in which I hypothesized I would not expect relief because of hot temperatures with COVID-19. And the reason was so many people were susceptible. At the time I wrote, at most, maybe 4% of the population had been exposed. And with 95, 96, 97% of the population still susceptible to the virus, it was going to have no difficulty spreading, I didn't think. And, of course, unfortunately, that obviously is the case throughout the South and throughout the country, particularly in the South where it's really hot. I'm in New Orleans, hot and humid. The heat has not stopped transmission. Oddly enough, fortunately, it has actually interfered with transmission, but it's not, not enough to stop it. But it has affected the whole wave phenomenon. We still run the risk, and this is of great concern. It should be to everybody. It certainly is to me, that if we do not get the baseline of transmission way, way down, when the weather does in fact turn colder and more people do tend to be inside, then it's going to get a lot worse. It's hard to fathom that, as bad as it is right now. But I think it's not only possible, but even likely if we don't manage to get this thing put back in a box. The encouraging thing is that we can do it. Every developed country in the world, except the United States, has managed to get a handle on the virus. Every one of them. It's not just the Asian countries, where you can argue, well, their culture is different. It's easier for them to wear masks and so forth, and they are more communitarian and, cooperative and all that, whether that is or isn't true. Italy, France, Germany, Canada, United Kingdom, New Zealand, societies just like ours have done a great job. Germany's cases is fewer than 400 a day. Italy's cases is fewer than 200 a day. Italy's population is double Texas, twice Texas, and they have fewer than 200 cases a day. So per capita, that would mean, for Texas, that would be equal to fewer than 100 cases a day. If Texas had less than 100 cases a day, there wouldn't be even a debate about reopening schools. Of course, they'd be ready to open. There wouldn't be a debate over football. Of course, the football season would go forward. There wouldn't be a question about whether bars should be open or not. Of course, they would be open. The economy would be going full ball. But we didn't do it. And we didn't do it because our political leadership failed to advise us to do it. The public health experts did, and now we are where we are. I know a lot of Texas hospitals are right at their ICU beds are basically, their units are full and so forth and so on. And, fortunately, we've gotten much, much better at treating the disease itself. We know how to take care of it. We know there are blood clots, so you give anticoagulants. We know the immune system is fighting so hard to kill the virus in the lung, the so-called cytokine storm, that we are suppressing some of the immune system's action so that cytokine storm doesn't kill you, and so forth and so on. We've done a lot better treating it, brings the case mortality down below, but it's still higher than it should be if we use the public health measures.
You co-authored an article a couple of months ago, and it was through the Centers for Infectious Disease Research and Policy at the University of Minnesota. And you were talking about influenza in 1918. And I know it was a group of you that wrote this article, but I found it kind of interesting. Looking to the future, there were three scenarios that were described. peaks and valleys. A big fall peak or surge or a slow burn. Since you've written that article, have you thought much more about it on which one of those scenarios you think it's going to go?
Well, as we wrote in that article, and actually in fact, it came out almost the same day, but I didn't realize that study was coming out the same day I wrote the op-ed about waves. We said it's impossible to predict because we don't know what compliance there would be with the public health guidelines. We knew when we wrote it was possible to keep the virus in a box if we did things right. And we also knew that if you did everything wrong, you have a worst case of several million deaths. Right now, obviously, things are not going well. I guess in the op-ed, the way I described it, and I'm more familiar with the phrasing I put in the op-ed, but it sounded more technical in that study you're saying, but it's essentially the same thing. I said that I expected to see a series of swells with the occasional white cap more than an outright wave or a storm surge. I said if things, living in New Orleans, think about hurricanes, but if we don't do things right, we could see a hurricane storm surge. Obviously, we've seen more than a swell with an angry white cap. It's a lot bigger than that. It's not quite a hurricane storm surge even now. But the one good thing about it is that compliance with public health recommendations are going up, not down. In 1918, a lot of the same things happened, but people got tired of it over time. And compliance, which was very good at the beginning, tended to decline as weeks passed because people got tired of it. This time around, the problem was reversed. Because too many people didn't take this seriously, which I think was a direct result of what the White House was saying and what a few other people, some state and local officials, people didn't take it as seriously as they should have. And, reopening too soon and things like that. And the result is this surge that we're experiencing right now. But now people are taking it seriously. The compliance with masking is going up. We're taking this a little bit in advance of Sunday. And just yesterday, Trump sent out a tweet with picture of himself in a mask, talking about that some people, he wasn't willing to say he thinks it's patriotic to wear a mask, but at least he said that some people think it's patriotic to wear a mask. So that's a major step forward if he keeps to that message. So things could improve. Now, Robert Redfield, the director of the CDC, said if everybody wore a mask, that he thought we could get this back contained in 4, 6, 8 weeks. I don't know that he modeled that. Personally, I think that's a little bit over-optimistic. Masks alone are not going to do the trick. In fact, I think social distancing is more important than masking, but masks are very important. I think if everybody wore a mask, if everybody social distanced and so forth and so on, then I believe you are certainly going to blunt the explosive growth that we've had, particularly in Texas. And you would certainly bring the curve down and point it in the correct direction. But I don't think those things by themselves in a period of a few weeks or, 6 weeks, I don't think they would bring it down to the baseline that you need to have as you're going into the fall. That was really the problem with the surge is we never got the baseline down. But that, that all remains to be seen. Hopefully virtually everybody will start wearing masks. I know Louisiana, of course, is a red state. And I can tell you over a period of weeks, there are a lot more people on the street wearing masks today than there were a month ago, much less 2 months ago, even in the middle of the lockdown.
You're listening to John Barry, author of The Great Influenza, the story of the deadliest pandemic in history, of course, back from 1918. When we come back, the big question on many North Texas families' minds right now is what about going back to school? John Barry, who's one of the leading authorities on pandemics today, takes that one head on when we come back. And if you missed part of this interview, you can grab it on our podcast. It is on all the major podcast players. Look for The Human Side of Healthcare. And we will be right back.
The DFW Hospital Council, along with our over 90 member hospitals in North Texas, are proud to bring you the human side of healthcare with Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome back to the human side of healthcare. We're going to continue our discussion with John Barry. We're going to learn about opening schools and the economy.
John Barry is the author of The Great Influenza, the story of the deadliest pandemic in history. And he's a distinguished scholar at Tulane University. And he is going to tackle the question that many North Texas families are asking right now. Is it safe to go back to school?
You know, that's a very interesting question. And in terms of people involved with public health, whom I know, I would be on the aggressive side of most of them in terms of opening schools for several reasons. First, closing them initially was sort of a knee-jerk reaction. Because in an influenza pandemic, all the plans call for closing schools. In influenza, we know that kids are super spreaders. Number one, they get sick themselves, and young children are particularly vulnerable to influenza. The very young and the very old are usually the victims of influenza, although that was not the case in 1918, when people in their 20s and 30s, most of the deaths were relatively young. So we know that kids are very vulnerable. We also know they're super spreaders. So in influenza, it's almost automatic that if you have a serious outbreak, you close the schools to protect both the kids and the community. But this virus is a different virus. Number one, kids are getting less sick than adults. And number two, the older kids probably spread disease roughly the same as adults, but the younger kids may not even spread that much disease. So the schools are not a special case in COVID-19 the way they are in influenza. However, you do have plenty of vulnerabilities. Obviously, the kids, they go to school and the teachers, some of them older, you have the custodians, you have the grandparents the kids visit, you have, parents. All these people may be considerably more vulnerable, and some of them may be very vulnerable. Particularly the older kids do transmit the disease probably about the same as adults. So the key to getting schools open is that they're not a special case, but they're the same case. The key is community transmission. If community transmission is high, which it certainly is right now in many parts of the country, including Dallas, then you would be crazy to open schools. If you get the baseline down, and I don't have a minimum number, I wish I did. Certainly, if it were 1 in 100,000, I think that would be pretty safe. Right now, the country is probably about 19 cases per 100,000. I'm not sure exactly where Texas is. Louisiana is about 45 cases per 100,000. If you get it down to about 1 case per 100,000, which would be significantly ahead of where the average in the country is right now, then I would think there's no reason not to open the schools. And I would strongly support opening the schools. But when you have high community transmission, no.
What about the economic impact? What happened in 1918, and do you see any parallels today?
There have been several studies, actually pretty recently, by 2 different Federal Reserve banks that track the economies in different cities in 1918. And they found that the cities that stayed closed the longest had significantly better economic recoveries than those cities which did not. And that's kind of interesting. But one of the big differences between COVID-19 and influenza is duration, starting with the incubation period. 1 to 4 days for influenza, 2 to 14 days for COVID, how long it takes the disease to develop, how long you're sick, how long you shed virus. All these things are much longer, generally 3 times as long for COVID-19 as for influenza. And that creates different economic stresses, and whether it's seasonal influenza or the 1918 pandemic. When influenza hits a city, it's generally takes 6 to 10 weeks before it peaks and then pretty much leaves. In 1918, probably 2/3 of the total deaths over a 2-year period occurred in about 14 or 15 weeks. in the fall of 1918 worldwide, but in any particular location, it was generally considerably shorter than that. We're already at, this is July, late July, so we're almost 7 months into this, and obviously it ain't going away, and there's no sign of it going away, even to abate, to give us some relief. So the economic stress from this disease is considerably greater than the economic stress that was put on in 1918. It was very intense in 1918, but it was over in a much shorter period of time. So the comparisons aren't that useful, except to note what I said already, that according to a couple of Federal Reserve studies, the cities that stayed closed the longest had better economic recoveries.
They took the pain for the long-term gain, didn't they?
Exactly.
You talked about the time frame. You said this isn't going away anytime soon. Do you have a time frame projection? SARS came and went. How long are we going to be talking about COVID-19 every week on KRLD?
Well, I don't know how long you're talking about it, but I think it's here forever. SARS was entirely different. We managed to completely eliminate that from the human population. That's because SARS was not easily transmissible. This virus is entirely different, either asymptomatic or pre-symptomatic transmission. Unless you get a really, really effective vaccine, something like measles, which is in the high 90%, this virus is here to stay.
That's ominous. That's not what everybody just wanted to hear.
Well, I think we'll have drugs that will be effective. You do have two drugs now, the steroid dexamethasone, if I said that right, and remdesivir, that are probably cut mortality rates, and just the way we've learned to treat people, treating maybe the damage that the virus does, as I said earlier, anticoagulants to handle the blood clots, immunosuppressives to prevent the cytokine storm. We've gotten a lot better at not automatically putting people on respirators when their oxygenation goes down. We saved a lot of lives by learning how to handle the virus, even with just supportive care. A vaccine is going to make significantly more progress. I'm very optimistic, not that I'm a virologist, but we know that the target for a vaccine, the so-called spike protein, is very stable. And if the target is stable, then you ought to be able to hit it. It's different from influenza, where the target for the vaccine mutates very rapidly, which is why you need a new shot every year. Even if you need repeated shots for coronavirus or boosters, they will significantly cut down both illness and severity of illness. And in the meantime, we've got a lot of drugs that are going to be tried out to see what impact they have. Just this week, a form of interferon beta that you inhale, a very tiny, very small trial, but highly successful in preventing serious disease. And I'm sure the monoclonal antibodies, those are probably come online. We have high hopes for them. So even if the disease sticks around for a long time, essentially forever, the treatments and the preventions should improve dramatically. And finally, there's a hypothesis that just your own immune system, once you've been exposed to the disease once, your immune system might get pretty good at preventing it naturally, or at least preventing a serious attack naturally. So even though the virus is going to be around indefinitely, it's not going to be as ferocious as it is now.
I was reading in your acknowledgement, and this caught me. I really thought about it. You said that your intent was to write this book in 2.5 to 3 years, but unfortunately your plan didn't work out. It took you 7 years. Can you expand on that?
Well, the funny thing was I never intended to write the book at all. What I wanted was to write a book about the home front in World War I, which culminated in events in 1919, which is, in my view, one of the most interesting years in American history. Obviously, I ended up getting diverted into this book, and I did co-author a book called The Transformed Cell with Steve Rosenberg, who's the chief of the surgery branch at the National Cancer Institute. So that gave me a very solid understanding of immunology, without which the book would be very different. had I gone into this cold. So given that background, I thought that I could do the book pretty quickly. And anyway, I was sadly mistaken. For the first 5.5 years, I hated the fact that I started it, wanted to throw it out every day, but the publisher had given me an advance and I didn't have the money to pay it back. So there was a character in the book named Oswald Avery, who's, I think, probably the single person most deserving of a Nobel Prize who never won one. And he had a terrible time. I mean, almost destroyed his life, this project he was on that started with the influenza pandemic. But for 25 years, he pursued this question that he was trying to understand, and basically had a nervous breakdown, in my view. Didn't publish anything for more than 10 years, which for a scientist, that's what they do. That's like a football coach losing. A good scientist has hundreds of publications. He didn't have any over a period of years, and still believing in what he was doing. That's the key. He persisted. He kept with it. And at the end, he came up with probably the most important discovery in the biological sciences of the 20th century. The DNA carries a genetic code. But anyway, looking at Oswald Avery, all the struggles that he went through, at least kind of kept me going. But just about the 5.5 year mark, things started to come together for me as a writer, and started figuring the book out, and was at the end quite happy that I had started it.
Author John Barry, and the book is The Great Influenza, the story of the deadliest pandemic in history. If you missed some of John's interview, it's on our podcast. Just search for The Human Side of Healthcare. And coming up next, a legal perspective on telemedicine. Quick break, we're back on The Human Side of Healthcare.
We're continuing our conversation on how you can empower yourself to have the best health possible in today's ever-changing healthcare environments. This is The Human Side of Healthcare with DFW Hospital Council President and CEO Stephen Love and co-host Thomas Miller.
And welcome to The Human Side of Healthcare. We're delighted that you're with us today. We've done some shows and talked a little about the clinical aspects related to COVID-19, virtual care, telemedicine, but we thought it would be good to get a viewpoint, especially from an attorney. And we're delighted that we've got with us today Chris Eades. Chris is a shareholder with Hall Renda. Chris, welcome to the show.
Thanks so much for having me.
Let's roll the clock back a little bit, Chris, if we could. Prior to COVID-19, what would you say some of the traditional barriers were in practicing virtual care?
Well, I would boil it down to 3 really significant barriers. Those would be very limited reimbursement, significant regulatory variability among the states and even within the states. And then thirdly, I would say there can be some significant cost of entry in terms of the technology involved.
Those 3 areas are very important. Let's first talk about reimbursement. You're so right. I've heard a lot of the insurance companies just wouldn't cover a virtual visit. Do you want to elaborate on that?
So it really starts with Medicare. And pre-COVID-19, there were some significant restrictions in terms of the type of telehealth service that would be eligible for reimbursement. The first restriction pertains to the originating site. When we say originating site, we mean where the patient is located at the time of the telehealth service. There were 2 significant restrictions in place there. The first is a geographic restriction. Essentially, these patients needed to be located in a rural health shortage area. And then a second requirement being practice location. And that list was long in terms of the types of healthcare facilities, but what it did not include, save for a few exceptions, was the patient's home. So those were the 2 significant Medicare restrictions in terms of originating site. And then beyond that, we've had a restriction in terms of the types of healthcare providers that could qualify to render these services for purposes of Medicare. That was a fairly short list, did not include practitioners such as physical therapists, speech therapists, etc. And then in addition to that, the services services themselves were quite limited in terms of what would qualify for reimbursement. So pretty significant restrictions from a Medicare standpoint.
You know, and then when you talk about the different states, I know Texas a couple of years ago finally really made some significant changes related to telehealth and telemedicine. But as you look at all the different frameworks within the states, that clearly is problematic also, isn't it?
It is, and that's a great segue into that kind of that second bucket of barrier, being what I would call professional practice considerations. It's just a tough regulatory framework to track because each of the states do this differently. Most states at this point, not all, but most have some sort of telemedicine or telehealth statute, but they're all using slightly different definitions in terms of what those terms mean. How Texas defines telehealth and telemedicine is different than how other states use those terms. And we see lots of variation in terms of restriction, consent requirements, prescription rules. So it's very difficult, particularly difficult if you're going to be practicing in more than one state, which is often the case with telehealth. So there's a lot to pay attention to and still a lot of unanswered questions as a result of that variability.
Yeah, and as you indicated, the third barrier is certainly the expense, lack of Wi-Fi in certain areas. So let's step back a minute. How have these barriers been removed or changed or modified now that COVID-19 has come into play?
Sure. And we have seen a lot of significant change in response to the states of emergency. Most significantly, we've seen those changes with reimbursement, and in particular, what CMS has done with Medicare reimbursement. Really expansive changes made very early in the state of emergency. First and foremost, to do away with the geographic and location restrictions that I mentioned. So in essence, a patient can be located anywhere in the United States and also in the patient's home and be eligible to receive telehealth services. That was an exception that was made very early on and very expansive for the obvious reasons. Since then, through multiple rounds of waivers and exceptions and interim final rules and the CARES Act, we've seen a fair amount of additional expansion beyond that. So with respect to eligible telehealth providers, for example, it's no longer that short list that I previously mentioned, but at this point, really any provider who can render services through Medicare may qualify to render telehealth services. And then in addition to that, we've seen really significant expansion with the types of services that will now qualify as an eligible telehealth service. Beyond that, we've seen now the ability for rural health clinics and FQHCs to bill for telehealth services. We've seen expanded opportunity for physicians to supervise other clinicians through telehealth. We've seen expansion with respect to home health and the use of telehealth there. So really significant expansion with respect to Medicare reimbursement. Medicaid in many ways has followed suit. And then again with commercial payers also, we've seen similar movement there, but more variable and a little more difficult to track in terms of those exceptions perhaps changing more irregularly than what we see currently with Medicare.
And then, Chris, what would be your advice to people who have had a telemedicine visit and it worked really well for them? They'd like to see it continue. They caught the wave, in essence. What would you advise?
Sure. Well, I think in a couple different ways. One is I think it's important to be vocal in terms of, as a patient, whether you enjoy this format, whether you would like to see this to be a permanent format. You know, different folks have different opinions. We do read a lot about anecdotal sort of stories in terms of patients that have said, you know, hey, I really enjoy the option of not having to drive into the office. In fact, there was an article a few days ago, I think in USA Today, and it actually spoke to a patient located in Texas that was apprehensive about seeing their practitioner because of COVID-19, but was able to use a telehealth format, ended up having a few different visits for what seemed to be something relatively minor. But after having those visits and then with the condition not improving, ultimately learned that she had a really significant medical condition that needed urgent treatment. And from her standpoint, the use of telemedicine during the state of emergency really saved her life. So, with all of these question marks in terms of what will be made permanent, how easy will it be for healthcare providers to use telehealth, I think it's important for patients to be vocal, both to let their providers know what's working and what's not, but also hopefully to facilitate some change at a governmental level in terms of CMS and medical licensing boards and et cetera, really seeing the advantage here. And then I'd say secondly, and I would say this to any patient, but I think especially using a format that's new to them, don't be afraid to ask questions. This interaction is going to be a little different because it's going to be through telecommunication technology. And if you have questions about that format or follow-up or access to medical record, ask those questions.
And a big thanks to Chris Eades, a shareholder from the law firm Hall Render, with offices around the country and here in the Metroplex. The hurdles and opportunities in telemedicine, something I think we all hope is here to stay. We have extended interviews, including the ones you've heard today, on our podcast. It's The Human Side of Healthcare on all the major podcast players. And if you have a question or comment, you can reach us at radio@dfwhc.org. Have a great, safe week. Keep that mask on, and we'll see you next week on The Human Side of Healthcare.